As indicated in the introduction podcast, this presentation consists largely of questions with an explanation for incorrect distractors and a brief discussion of the subject. Pause the recording to answer the questions and to digest the graphics elements, the tables, etc., if necessary. These are the keywords relating to the pituitary items that have appeared on the in-training and board examinations over the last several years. B indicates the keyword was cited in the basic exam. A indicates it appeared in the advanced exam. U indicates it was used before the exam was divided into basic and advanced portions, so it was unspecified. And M indicates that the item was used in the maintenance of certification exams. The items appearing in red will be discussed in the podcast. Here's the first question. Remember to pause the playback in order to have sufficient time to review the question and select your response. Patients with diabetes insipidus are hypernatremic. A serum sodium of 140 is within normal limits. A urine sodium of 40 is greater than normal and is consistent with SIADH, not diabetes insipidus. Patients with diabetes insipidus have a plasma osmolality greater than 285, so the answer is potentially correct. However, a plasma osmolality of 290 is within normal limits. In addition, there is a better answer to this question. Patients with diabetes insipidus produce a dilute urine. A urine osmolality of 290 is below normal limits, so this is the best answer to this question. For the sake of completeness, I have included a table comparing laboratory values for diabetes insipidus, SIADH, and cerebral salt wasting syndrome. Pause the video to review the values if you're interested. Here's the second question. This slide shows the hormones secreted by the anterior pituitary. Pituitary dysfunction may occur as a result of infection, infiltration by a space-occupying lesion, trauma, surgery, radiation, or infarction. If the cause is pituitary adenoma or radiation treatment, gonadotropin and growth hormone deficiency tend to occur first, with relative sparing of thyrotropin and corticotropin function. This illustration demonstrates the consequences of panhypopituitarism as opposed to isolated anterior pituitary dysfunction. Growth hormone deficiency also results in fatigue, decreased exercise capacity, dyslipidemia, insulin resistance, which was one of the distractors, and increased cardiovascular risk. TSH deficiency results in hypothyroidism, which is manifested by fatigue, lethargy, weight gain, and bradycardia, as well as anemia, which were two of the distractors. ACTH deficiency produces central hypoadrenalism, manifested by fatigue, weight loss, nausea and vomiting, orthostatic hypotension, and diffuse arthralgias. Note that because this shows the consequences of panhypopituitarism, it includes the manifestations of ADH deficiency, that is diabetes insipidus, which does not occur with isolated anterior pituitary deficiency. This is the third question. Although stimulation of alpha-1 receptors produces vasoconstriction, these are adrenoreceptors. Vasopressin acts on vasopressin receptors, not adrenoreceptors. This table lists the effects produced by stimulation of the different vasopressin receptors. From this, it's evident that vasoconstriction occurs as a result of stimulation of vasopressin 1A, also known as vasopressin 1 receptors. This table simply lists the effects of different vasoactive agents and their primary sites of action. Note that there seems to be less renal vasoconstriction with vasopressin than with alpha agonists because there are fewer vasopressin receptors present in the kidney. Pause the video if you want to review the table in more detail. This table lists some indications for vasopressin administration. Note that vasopressin causes a displacement of peripheral blood volume to the central circulation. Recommendations are that it be administered only once during cardiac arrest due to the fact that it has a 10 to 20 minute elimination half-time. Here's a list of some vasopressin side effects. Note that splanchnic vasoconstriction will result in decreased hepatic blood flow. There is less of an increase in pulmonary vasoresistance than in systemic vasoresistance. Finally, note that small doses of vasopressin may produce selective coronary vasoconstriction. Here's the last question. This question gets to the point of the efficacy of adrenergic drugs in the presence of acidosis. Years ago, ACLS guidelines called for the administration of almost immediate and repeated doses of sodium bicarbonate in the circumstance of cardiac arrest. The rationale was that acidosis, especially metabolic acidosis, limited the efficacy of epinephrine and other alpha agonists on alpha receptors. Obviously, the recommendation regarding sodium bicarbonate has changed, but the concern about the potential effects of acidosis on adrenergic receptors has been used as an argument favoring the use of vasopressin in cardiac arrest. Thank you. I hope you found this podcast useful.